Hello, my name is Dr. Andrew Siegel. I'm a urologist who practices out of Hackensack, New Jersey, and I would like to speak to you about post-prostatectomy urinary incontinence. Basically, post-prostatectomy urinary incontinence is urinary leakage that is a result of surgery on the prostate. Most of the time, this is as a result of a radical prostatectomy done for prostate cancer, although on an occasional basis it can be as a result of surgery done for benign causes. The incidence of stress incontinence, defined as leakage with stress maneuvers such as sneezing, coughing, laughing, etc., is anywhere from 2.5% to 87% in a variety of series, depending on how you define urinary incontinence. The occurrence of total incontinence is approximately 5%. That means 1 in 20 men after radical prostatectomy may have a severe situation in which there is virtual total emptying the bladder involuntarily. And this typically occurs with gravitational maneuvers such as standing up, or sudden increases in abdominal pressure such as bending over or coughing. Now, the good news is that the problem is getting better and better as the technique of radical prostatectomy is becoming more and more refined. With the latest techniques in laparoscopic and robotic procedures, the incidence of severe incontinence is becoming less of an issue as it was in years prior. But nonetheless, even with the most refined and current techniques, a small percentage of men are going to be rendered incontinent and severely unhappy with the resultant quality of life issue. So, in general, urinary incontinence as a result of prostatectomy results from damage to the sphincteric closure mechanism of the urethra, resulting in a fixed, open, scarred neck of the urinary bladder. That's the typical appearance when we look inside the bladder with a lighted instrument called a cystoscope. And it causes what is referred to as a pipe stem urethra. The urethra, instead of closing nicely and being supple, is in a chronic open state. It looks like the Lincoln Tunnel, essentially. I like to use the analogy of a brittle washer in your sink, as opposed to a supple washer that closes effectively. Now, risk factors for incontinence after radical prostatectomy include being older, having had prior prostate surgery, the need for postoperative radiation, having a higher stage cancer, undergoing a nerve sacrificing procedure, or having the complication of a bladder neck contracture postoperatively, a condition in which there's scarring that requires either cutting the bladder neck or dilating the bladder neck. Now, as far as management of post-prostatectomy incontinence, pads, appliances, pelvic floor muscle exercises, bulking agents, male sling procedures, or the artificial urinary sphincter. This demonstrates a penile clamp, a rather crude device that basically pinches off the urethra. This shows a condom catheter, that's a condom placed on the penis attached to a bag that drains urine. There are several different bulking agents that can be injected into the periurethral tissues that can bulk up the urethra. Collagen used by plastic surgeons to bulk up lips, for example, can be used to bulk up the urethra, but in general, these bulking agents have not resulted in excellent long-term results, as some other means of treating the problem have. There are several different forms of the male sling, and a male sling is very similar to a female sling that is used for stress urinary incontinence. The advanced male sling is essentially placement of bone anchors and attaching to these bone anchors a piece of material that puts pressure on the part of the urethra that goes underneath the scrotum to attempt to increase the resistance and closure pressure of the urethra. A newer form of sling is called the advanced male sling, and this is placed through the obturator opening in the pelvis, very similar to the transobturator approach in females, and this is providing early, encouraging results for mild to moderate incontinence. If a man has severe or total urinary incontinence, he will probably end up needing the artificial urinary sphincter if he wants to have a return to good quality of life. This essentially is the gold standard for post-prostatectomy incontinence. It's a hydraulic device made of silicone. Generally, it can be placed on an outpatient basis in less than an hour. This is an example of the artificial urinary sphincter. It has 3 pieces. This is an occlusive cuff that is implanted around the urethra and provides the closure pressure. This is a reservoir, or also known as the pressure regulating balloon, which is implanted in the retropubic space near the bladder, and when inflated with fluid, it controls the amount of pressure exerted by the cuff. And this is the control pump that is implanted in the scrotum, and it contains the resistor and the valves for transfer of fluid to and from the cuff. Now, the results of an artificial urinary sphincter are 90% great improvement with occasional minor stress leakage with vigorous activities. Approximately 50% of men are completely dry. The side effects can include mechanical malfunction, as can result from any implantable device, erosion, in which one of the components can wear through the skin or into the urethra, and a urinary infection. This slide depicts the placement of the 3 pieces of the artificial urinary sphincter: the cuff around the urethra, the pressure regulating balloon adjacent to the bladder, and the pump in the scrotum. This is a photograph of the pressure regulating balloon, a photograph of the pump, and a photograph of the cuff. And this is the cuff around my index finger, and when pressurized, it exerts pressure much as a blood pressure cuff does around your arm. This slide depicts the adequate functioning of the artificial urinary sphincter. This is the condition for most of the day, in which there's fluid in the cuff that occludes the urethra. When the possessor of the artificial sphincter wants to urinate, he simply compresses the pump, and what that does is, by squeezing the pump, it moves fluid from the cuff to the balloon, allowing urination. And within a minute or so, the fluid refills the cuff automatically. In 2003, Dr. Wilson and myself and several other authors wrote up in the Journal of Urology a new surgical technique for sphincter urinary control system using a single incision as compared to the previous dual incisions necessary, one in the abdomen and one in the perineal area. And now I implant the vast majority of artificial sphincters through a single incision in the upper scrotum. This final slide shows the cuff in action via the cystoscopic photograph of the urethra. The top left shows the effect of the cuff inflated, the top right, the cuff deflated, and then the bottom slide shows the cuff gradually refilling with time. So in summary, post-prostatectomy urinary incontinence is a rare but devastating quality of life issue for a man after prostate surgery, but can be helped to a great extent by current technologies that we have at our disposal.